Every year, millions of seniors have their blood pressure checked, their cholesterol measured, their blood sugar monitored, and every year some of those seniors, with acceptable blood pressure, acceptable cholesterol, acceptable blood sugar, go on to have heart attacks and strokes that nobody predicted, not because the monitoring was done carelessly, but because the monitoring was measuring the wrong things. Blood pressure tells you the force of blood against the vessel wall right now. Cholesterol tells you the level of lipids in the blood right now. Blood sugar tells you glucose control right now. None of them tell you the state of the arteries themselves, the actual structural condition of the walls of the blood vessels through which all of that blood is flowing. And the structural condition of the arterial walls is where the real story of cardiovascular risk is written, years before a heart attack, years before a stroke, while everything else looks acceptable. Today we are going to tell you about a test that directly images the arterial wall, measures its thickness, detects early plaque that no blood test can find, and has been validated across decades of research as one of the strongest available predictors of cardiovascular events in the years ahead. It is non-invasive, it uses ultrasound, it takes approximately 15 minutes, and it is recommended by cardiovascular medicine guidelines for risk assessment in adults over 60 with intermediate cardiovascular risk. Most seniors have never heard of it. Almost none have been offered it in routine care. It is called Carotid Intima Media Thickness Measurement, CIMT, and by the end of this video you will understand exactly what it measures, what the results mean, who should be asking for it, and what to say at your next appointment to get it done. Let us start by understanding what the test is actually looking at. Your carotid arteries are the two large arteries that run up each side of your neck and supply blood to the brain. You can feel them pulsing if you place 2 fingers on either side of your windpipe. These arteries, like all arteries, have walls made of layers of tissue. The 2 innermost layers are called the intima and the media. Together they form the inner wall of the artery. In a young, healthy artery, this inner wall is thin, smooth, elastic. Blood flows through it cleanly with no resistance and no obstruction. But as atherosclerosis, the process of arterial disease, develops, several things happen to the inner wall. Inflammatory cells and lipid particles accumulate beneath the surface of the intima. The wall begins to thicken. Over years, the thickening progresses. Small plaques begin to form. The artery loses some of its smoothness and elasticity. Blood flow becomes slightly more turbulent. The risk of a clot forming, or a piece of plaque breaking off and traveling to the brain, increases. This process begins decades before any cardiovascular event occurs, decades before any standard blood test flags anything concerning. CIMT, Carotid Intima Media Thickness Measurement, uses ultrasound to measure exactly how thick that inner wall is. A normal inner wall measures less than approximately 0.9 millimeters in most adults. As it thickens, indicating developing atherosclerosis, the measurement increases, and the relationship between increasing CIMT and increasing cardiovascular risk has been documented in large population studies over more than 30 years. The Cardiovascular Health Study, the MESA study, the Rotterdam study, multiple large prospective investigations, all showing the same consistent finding. As CIMT increases, the risk of heart attack and stroke increases significantly, independently of blood pressure, independently of cholesterol, independently of other traditional risk factors. A CIMT measurement adds meaningful predictive information above and beyond what traditional risk factors alone can provide. Why does CIMT predict risk that blood tests miss? Because it is measuring the consequence of risk factors rather than the risk factors themselves. Imagine 2 people. Both have LDL cholesterol of 3.2 millimoles per liter. Both have blood pressure of 135/82. Both are the same age. Both have similar lifestyle histories. Their traditional risk factor profiles are nearly identical. A standard risk calculator would give them very similar 10-year cardiovascular risk estimates, but their arteries tell completely different stories. Person A has a CIMT of 0.7 millimeters, thin inner wall, minimal plaque. The risk factors have been present, but the arteries have responded to them with little structural change. Person B has a CIMT of 1.1 millimeters, a wall nearly 60% thicker, early plaque detectable at several locations. The same risk factors have produced significant arterial wall change over time. Person B has a substantially higher actual cardiovascular risk than their blood test numbers suggest, and person A may be able to safely manage their risk with lifestyle changes alone rather than aggressive medication. The CIMT tells the clinician which person they are actually dealing with. The blood tests cannot. This has 2 practical implications. For people who appear to be at intermediate risk based on traditional factors, CIMT can reclassify them as higher or lower risk, changing treatment decisions. either intensifying therapy in people whose arteries show more damage than expected, or avoiding over-treatment in people whose arteries show less damage than risk scores predict. For people who appear to be at low or acceptable risk based on traditional factors, CIMT occasionally reveals significant subclinical atherosclerosis that would otherwise go undetected until the event that detects it for the wrong reason. What does the test involve? The test is entirely non-invasive. There is no blood draw, no injection, no radiation. You lie on an examination table. A gel is applied to the side of the neck. An ultrasound probe is placed against the skin over the carotid artery. The sonographer images the artery wall in multiple locations on both sides of the neck. The software measures the thickness of the inner wall at multiple points. It calculates an average and identifies the maximum thickness measured. It looks for the presence and characteristics of any plaque. The entire procedure takes approximately 15 to 20 minutes. The results are typically discussed immediately or at a follow-up appointment within a short time. There is no discomfort, no preparation required beyond attending the appointment, no recovery time. What the results mean in plain language: normal. Inner wall thickness below 0.9 millimeters with no significant plaque detected. This indicates that arterial aging is within normal range for your age. Your cardiovascular risk management can continue as currently planned, mildly thickened, between approximately 0.9 and 1.2 millimeters. This indicates early arterial wall thickening. The process of atherosclerosis has begun. Risk management should be reviewed and intensified where appropriate, significantly thickened or plaque present, above 1.2 millimeters or with clearly visible plaque. This indicates established subclinical atherosclerosis. Cardiovascular risk is meaningfully elevated regardless of what traditional risk factors show. Aggressive risk management is warranted. This finding should prompt a comprehensive cardiovascular review. The finding of plaque specifically, a focal thickening or elevation of the wall surface, carries additional significance beyond the thickness measurement alone. Plaque composition and surface characteristics visible on the ultrasound provide additional information about whether the plaque is stable or potentially vulnerable. The distinction between plaque that is unlikely to cause an event and plaque whose structure makes it more likely to rupture. Who should be asking for this test? Cardiovascular medicine guidelines identify several groups for whom CIMT provides meaningful additional risk information. Adults age 55 to 75 with intermediate cardiovascular risk. This means people who have some cardiovascular risk factors, blood pressure, cholesterol, smoking history, family history, diabetes, but whose 10-year risk based on standard calculators falls in the range where treatment decisions are genuinely uncertain, neither clearly low risk nor clearly high risk. Adults with a family history of premature cardiovascular disease. If a parent or sibling had a heart attack or stroke before age 60, your inherited risk may be significantly higher than your current risk factor numbers suggest. CIMT can determine whether that inherited risk has translated into actual arterial changes. Adults whose risk factor management seems appropriate, but who have ongoing clinical concern. A senior who has had consistently borderline cholesterol for years, or whose blood pressure is controlled but has been elevated for decades, their arteries may have accumulated damage that current readings do not reflect. Adults who are uncertain whether to start or intensify statin therapy. This is one of the most practically important applications. The question of whether to start cholesterol-lowering medication in someone at intermediate risk is one of the most common and most genuinely uncertain decisions in preventive medicine. CIMT provides objective arterial wall data that meaningfully informs that decision. A normal CIMT in someone with borderline cholesterol strongly supports a lifestyle management approach without immediate medication. A significantly thickened CIMT in the same person supports starting medication. Why is this test not routinely offered? This is a legitimate question, and it deserves an honest answer. CIMT requires a trained sonographer, specific ultrasound equipment, and time for interpretation. In healthcare systems under appointment pressure and cost constraint, these requirements create barriers to routine use. There are also ongoing discussions in the cardiology literature about which patient populations benefit most from CIMT versus other available tests. Some guidelines recommend it. Others suggest coronary artery calcium scoring, a CT scan measurement of calcium in the heart arteries, as a comparable or complementary approach. Neither of these conversations means the test is unavailable. It means it is not proactively offered. The difference between unavailable and not offered is important. CIMT is available at vascular imaging centers, at cardiology departments, and increasingly at preventive health clinics. It can be requested, it can be discussed, and for the right patient, an adult in their 60s or 70s at intermediate risk, uncertain about whether their risk management is adequate, wanting objective data about the actual state of their arteries. It is one of the most informative non-invasive tests available. What to say at your next appointment. Write these words down before your appointment. I am concerned that my cardiovascular risk may not be fully captured by my blood pressure and cholesterol results. I would like to discuss whether a carotid intima media thickness scan would be appropriate to assess the actual state of my arterial walls. I am particularly interested because of my family history and the fact that my traditional risk factors have been borderline for several years. Those words tell your doctor exactly what you are asking for and why. They demonstrate informed engagement, and they make it significantly more likely that the conversation leads somewhere useful. If your doctor is not familiar with CIMT or does not feel it is indicated for your situation, ask whether a coronary artery calcium score is an alternative they would consider. This is a related but different test that uses a low-dose CT scan to measure calcium deposits in the coronary arteries. It provides complementary information and is also recommended in guidelines for intermediate-risk adults. The goal is not to insist on a specific test. The goal is to ensure that your cardiovascular risk assessment goes beyond blood pressure and cholesterol numbers to include some assessment of what is actually happening inside your arteries. That assessment, whatever form it takes, is what your heart deserves. The most important thing to take from this video: traditional cardiovascular risk assessment tells you about the risk factors affecting your arteries. Arterial imaging tells you about the arteries themselves. Both types of information are valuable. And for adults over 60 at intermediate cardiovascular risk, the combination of traditional risk factor assessment with direct arterial imaging provides a more complete and more accurate picture of actual cardiovascular risk than either approach alone. You have been having your blood pressure and cholesterol checked for years. That monitoring matters and should continue. But your arteries have a story to tell that those numbers alone cannot narrate. CIMT is one of the most direct ways available to hear that story before it is told by an event you never had the chance to prevent.